share. Right, can you see that?
Yeah, we can see your slides now. Yeah.
Make it a slideshow. There you go.
Yeah, we can see it. Yeah.
Okay, cool.
Yeah, we can see it now. Okay, let's start. We are live on the Facebook. We are missing Sadhna Niaz at the moment, but I will take the liberty of starting the session. I welcome everyone for this special session where we have a guest speaker. I hand over to Dr. Saqib, who is going to introduce our worthy speaker and moderate the session. Over to you, Dr. Saqib, please. Thank you.
Thank you, Professor Alam, and thank you so much, Emily, for taking your time, and especially when this is your off day and you have to look after kids. And thank you very much for coming and educating us. Emily and me both together trained at Nottingham, and I remember the days with Professor Fox, Mark Fox, who taught us a bit about mobility, motility, and I found upper GI and esophageal disorders quite challenging, especially investigating is one part, but interpreting those investigations is very difficult. And that's where Emily comes in, and she has done her MD in esophageal dysmotility, and she has published extensively in renowned journals as well. And I'm very grateful for Emily to once again to help in now educating us about upper GI dysmotility and disorders. So over to you, Emily.
Okay, thank you very much for that kind introduction. I'm just going to do an overview of high resolution manometry, the principles behind it, the classification system, and then a few cases and scenarios as well. Okay, so thank you very much for the opportunity to talk. Okay, so esophageal function. We know that the purpose of the esophagus is to transport food from the mouth to the stomach and also prevent the return of food from the stomach into the esophagus itself to prevent reflux. When you get dysfunction in either of those things, it can lead to symptoms. Obviously, dysphagia being one of the most significant symptoms. Reflux and aspiration can also be symptoms too, and pain. Although, is that always related to function? It can be sometimes difficult to tell exactly what the cause of the pain is. Okay, so the aims of any principles of esophageal investigation is to understand the physiological basis of the dysfunction and therefore understand what is causing the symptoms to try and identify the pathological mechanisms. Because by doing that, it allows you to provide a meaningful explanation of those symptoms to guide your rational treatment. And as with any therapy or treatment we want to offer any of our patients, we want to try and improve quality of life. So high resolution manometry is a relatively new technique in the medical world and is allowing us to assess things in more detail to try and promote those achievements. So when investigating the upper GI tract, obviously we always start with clinical history and exam, as with any patient in any situation. If you're concerned about dysmotility or motility disorders, you would still always assess structure beforehand. And obviously patients would always generally undergo a gastroscopy before undergoing any high resolution manometry, because you need to know that things are structurally okay before you start thinking about motility and dysfunction. Radiology, some people are very pro always doing a barium swallow after a gastroscopy before going on to do any high resolution manometry. This can obviously identify things such as large hiatus hernias, which may not always be as apparent on endoscopy, pouches and other things like that. I think when dysphagia is a very significant symptom, it can sometimes be helpful, or whether the question is how much a hiatus hernia could be playing a role in the dysphagia that people have. Obviously, manometry has evolved over years. We previously had water-based manometry. We now have the high resolution, and we can have impedance data associated with that. So looking at your level of resistance, your number of ions there, to tell you whether there is fluid or air present. It can also tell you which direction it's traveling in and show reflux as well. We can also do reflux studies, which we would always do before going on to do any anti-reflux surgery in a patient. Obviously that can be done with impedance or without impedance, but generally requires the 24-hour study to occur. Going on, if you wanted to do other further studies, obviously I'm not going to talk about here today, scintigraphy, looking at gastric emptying, can be used. Not always the most helpful test, I find. I think with just having a T50 measurement, so one simple measurement as a representation of a very complex process that's involved in gastric emptying, it can be difficult for it to actually change your therapy or change what you're doing. Breath tests can be used as a marker of gastric emptying. Currently in my hospital in the area, they're not being done at the moment because of the risk of potentially COVID transmission with these. And I think MRI is an emerging technology which has a lot of wealth of information, but we are learning still about that, particularly in esophageal, a little bit more in stomach. Okay. So why would we do manometry? So dysphagia is probably one of the most common symptoms that we do manometry for. And what are we looking for? We're looking for primary motility disorders, with achlasia perhaps being the most typical, well, the most highly characterized one, although obviously not that common. You're then looking for spastic or hypertensive motility disorders, or your other end of the spectrum, your hypotensive or ineffective motility disorders. There's obviously secondary disorders, which are secondary to other diseases. Your classics being your connective tissue disorders, such as scleroderma, which are generally very much associated with hypomotility, or any obstruction to flow that may occur, particularly around the GOJ in these scenarios. Evaluation of non-cardiac chest pain, so pain that doesn't have a clear cause, can sometimes be a reason to do manometry and pH testing as well. And to evaluate reflux and regurgitation, particularly as I've already mentioned in the pre-surgical group, would expect anyone going on to have anti-reflux surgery to have manometry to look for motility disorder, and then pH studies as well to confirm that reflux is the cause of their symptoms. We evaluate peristalsis and the etiology of GERD. Obviously, the manometry also assists in the placement of the pH probe as well. Okay. So the high resolution manometry kit is a catheter with multiple sensors less than 2 centimeters apart. Previously used to be water perfused, but the high resolution manometry catheters are now solid state and give us a wealth of information in a much more interpretable and readable fashion than previously received. They use the information gathered from each of these little sensors over time, as the manometry recording obviously occurs over time, to create a spatial temporal plot of pressure data, with the different pressures being represented by different colours. So obviously this is a sort of plot that you previously would have got with manometry, which obviously can be quite difficult to interpret, can show things such as a peristaltic wave, but that information has been put together to provide these plots that are far more interpretable. So just to go over a bit of basics, I don't know how much people have learned or seen manometry before, just go over the principles to then be able to apply them to the other information that we have. So here we have a picture of a manometric plot. Okay, so what you can see here now, I hope you can see my mouse. You can see an upper esophageal sphincter here. So what we have here at the side is a pressure legend. So your purples and your reds, your brighter, your more intense colours are your higher pressures. Your blues and your greens are your lower pressures. And that's represented in the plot here. This is a recording, so this moves across with time. So this is probably, normally it's 10 seconds, these windows. This will be about a 30-second window. And this is the top, so this is where your mouth would be. And this is obviously the bottom, this is where your stomach would be. And you've obviously got the catheter going through the nose, down through the esophagus and into the stomach. So what we have here, first of all, just to orientate ourselves, is our upper esophageal sphincter. And you can see this is a band of high pressure here at the top, which is obviously under your voluntary control. What is happening here is there's a swallow here, so you're seeing that reduction in pressure here because you're opening your upper esophageal sphincter to allow the swallow to occur. What we have next is our lower esophageal sphincter at the bottom. So you can see this is a second band of pressure, a bit more prominent here. We'll talk about this bit a little bit later. And you can see it really become more prominent here following the swallow. Not quite as intense as the upper esophageal sphincter, not quite as powerful. But if you remember, obviously your upper esophageal sphincter is under voluntary control, while your lower esophageal sphincter isn't. As I say, what we see is a swallow. So you see that break in pressure here, and then you see the swallow occur. And what you get there is an appropriate deglutative relaxation when you swallow, when you open your upper esophageal sphincter. And that's obviously to allow whatever you've swallowed, whether that be saliva or food or drink, to be able to pass down with a peristaltic wave into your stomach, because you've got a nice open lower esophageal sphincter for that. And here we have a nice peristaltic wave. You've got your proximal, your mid and your distal, and there's normally a little break in the upper third here where you get your join of your different muscle types. So that's a normal appearance here. And what's important to note about this is not only the power is important for a good peristaltic wave that drives bolus into your stomach, but the coordination as well. We obviously get contraction at the upper esophagus that then progresses through the esophagus down to the lower end of the esophagus, but you get the subsequent relaxation behind it to allow that bolus to transport down. So this is our normal nice swallow in a high resolution manometry plot. Now, what you would do when someone had high resolution manometry is you would ask them to do 10 swallows of just a small amount of water to get a baseline of what their normal water swallows are like. You try and get them to swallow and then not swallow again for about 30 seconds if they can manage, so that you can really see what's happening to the lower esophageal sphincter afterwards and to the other areas. You get people to do 10 of these, so you get 10 water swallows. They then go on to do a multiple repeated swallow or a repeated water swallow, where you ask someone to drink approximately 150 to 200 millilitres of water to see what happens when they take that higher volume. Then a majority of centres would go on to do solid swallows as well. They're not in our classification system at the moment, but I think there has been a lot of work to show that they are helpful. And sometimes that greater challenge for the esophagus will show you pathology or symptoms a lot more. Or it may be that sometimes the esophagus, for the want of a better phrase, would rise to the challenge. So when faced with something a little bit more difficult to swallow, such as a solid, it can show you what power it possibly has, what physiological reserve to do that. Common things that you use are small bits of marshmallow or bread, or sometimes rice, because it's tolerated by most people. So just talk about a few of the principles, the normal things that we see in the classification system, so that we can try and interpret things that we can see abnormal. You can see that your pressure should be between sort of 10 and 35, and you should get appropriate relaxation of the lower esophageal sphincter. So obviously when you swallow, you will open that lower esophageal sphincter to allow bolus to travel into your stomach. You want coordinated peristalsis with a pressure front of more than 20 millimeters of mercury to allow that transport of bolus to occur. And you want your velocity to be less than 8 centimeters per second in more than about 90% of swallows, more than 9 out of 10 swallows as well. You'll normally get a rise in intrabolus pressure associated with your swallows, but not too high, because if it's too high, that's when symptoms would tend to occur. And this is just exemplifying that in this picture. The distal contractile integral, which I'll talk about a little bit more later on, essentially measures the vigor of the contraction and should be less than 5,000. Okay, so your IRP is probably the first most important measurement to look at, because it's representative of your lower esophageal sphincter relaxation. Measured in millimeters of mercury, and it's a median of 4 seconds of deglutitive relaxation from the upper esophageal sphincter relaxation. Now it should be up to 15 centimeters. Sorry, I've just got a text. I don't know if there's, yeah. So Keeb, you're just texting me about the presentation. I hope it's okay. All right. So it's a measure of lower esophageal sphincter relaxation, and up to 15 is normal, but 15 and greater is classified as abnormal. Now your distal latency is then important, and that's measured in seconds, and that's the time point from upper esophageal sphincter relaxation to your contractile deceleration point. And that's when propagation slows down, when it's not peristalsis that's pushing the bolus through, but it tends to be ampullary empty, and so much more reliant on gravity and things. And that's important because that applies to the coordination. So you want the appropriate distal latency, so that's occurring at the right time to make this peristalsis effective. Okay, so there's just these measurements represented in a plot here. So you can see your distal latency is this line from your upper esophageal sphincter to your contractile deceleration point, when that slowing starts to happen and when ampullary emptying takes over more. And you can see just this line, this gradient here, is your contractile frontal velocity. Okay, so your DCI, which we'll talk about in a little bit more detail, as I said, is essentially the vigor of the contraction, how big, long and strong it is. Now less than 5,000 is abnormal. 5,000 to 8,000, sorry, it's in millimeters of mercury per second per centimeter, is raised, but can occur in healthy volunteers or asymptomatic individuals. But more than 8,000 is always considered pathological and abnormal. Your contractile frontal velocity is the rate of propagation of your peristalsis, and is in centimeters per second, and would be 2.4 to 7.1 centimeters per second. And then your contractile deceleration point is when that peristaltic wave just starts to slow down. And as I say, it's much more ampullary emptying that occurs to allow the last bit of bolus to transport into the stomach. Okay, and these are just some representations of your DCI, and see how it's important to measure them in the appropriate place. Okay. So HRM provides us some objective measurement of the forces that drive bolus transport, because what we're trying to find is objective measures of what can be very subjective symptoms. So as I've already said, the peristaltic contraction and the coordination defines the motor activity. and what is normal and potentially symptoms. Intrabolus pressure and pressure gradient lets us know whether the activity is consistent with effective function, and both are important because symptoms normally or mostly only occur when dysmotility is accompanied by failed bolus transport. It's not that common for people to get symptoms at rest when they're not trying to swallow or do anything. So what I'll talk about now is our classification system. So the Chicago classification of dysmotility is what we use. It's currently on version 3, although version 4 is in progress. I'm not sure when that will be coming. And we'll just talk about things a little bit more in detail because it comes into play quite importantly when you are looking at interpreting the information that you're getting on the basis of symptoms. So the first thing you always look at is your IRP, because that's representative of your lower esophageal sphincter relaxation. So remember, 15 and above is classified as abnormal and high. So look at that. Is it greater or equal the upper limit of normal? And do you have any peristalsis? Because if you have a raised IRP, which indicates your lower esophageal sphincter is not relaxing appropriately, and you don't have any effective or good peristalsis, that's when you're in your achalasia categories with your subtypes 1, 2, and 3, which we'll talk about a little bit more on 1 or 2 of the next slides. If that's not the case, you move down to the next setting where you see, is your IRP the upper limit of normal, so 15 or more, and is there any instances of intact or weak peristalsis? So you have some occurrences of peristalsis, and this would indicate EGJ outflow obstruction. So that could be either your achalasia variant or your mechanical obstruction for whatever reason. And then is your IRP normal, so less than 15, and you don't have any peristalsis, or your distal latency is reduced, so moved back, or you have a DCI, so your vigor of your contraction is very big. In that scenario, you're into the realms of esophageal spasm. That's when your distal latency is reduced because it's happening too soon, that lower end of contraction. Your hypercontractile is when your DCI is greater than 8,000, or your jackhammer esophagus, and they are the main abnormalities with that. Next, if you get into your IRP is normal and you get some minor peristaltic abnormalities, we come into what we call our minor motility disorders. So you may have rapid contraction, you may have hypertensive peristalsis, or you may have your weak or your hypotensive peristalsis, which is probably the most common section in this group. And what's important to note about these part of the flow chart, particularly with above and below this dotted line, is that these 3 up here are considered to never be seen in normal controls or healthy volunteers, to only be seen in those with symptoms and pathological state. While in this scenario, in the bottom end, you can see some of these changes, but in people with no symptoms and not necessarily associated with any significant dysmotility. And I think the one where that really can occur is the hypotensive motility. You can see a lot of people with quite hypotensive motility who have no real symptoms, and that's probably because it's been something that they've had for a long time and that they've been used to. Okay, so this is our backbone of how to interpret your manometry, and really the IRP is the area to look at in most detail because that represents your lower esophageal sphincter. And it's important to note, is that relaxed or not, before you then go moving on to try and interpret the rest of the findings that you've seen. Okay, so I'll talk about achalasia, which, as I've said, is probably the most defined motility disorder that we have. It's probably also the one that has the most therapeutic options with success, which is why it's probably liked in the motility world, because it feels like it's something we can do a little bit more about it. So I've just got achalasia here. Oh, I've just lost my mouse, got it. So here, this is just a manometric trace. You can see the upper esophageal sphincter. There is a swallow here. It's been squashed a little bit, so you can just see a break in your pressure line there, and you can see there's no associated gluteal relaxation at all there. The lower esophageal sphincter has just sat there the whole time. Obviously, you'd get a formal report producing the absolute numbers from this as well. And there's absolutely no peristalsis at all, is there? So you can see here is a normal peristaltic wave, just as a comparator, and you can see the big difference. So it definitely looks abnormal, and we can see that lower esophageal sphincter is just not relaxing. Okay, so HRM has been classified, achalasia has been classified into 3 different sections. So we have our type 1, our type 2, and our type 3. So you can see here we have type 1, which is associated with no peristalsis. So you just get nothing there. You just see that band of lower esophageal sphincter pressure. Type 2 is with our panesophageal pressurization, which you can see in the example in the middle here. And then type 3 is our spastic achalasia, type 3, where you don't get relaxation of the lower esophageal sphincter and you have this big spastic looking contraction as well. And why are they important? Well, because the different types respond to therapies differently. Now, obviously, achalasia is where you don't get a relaxation of the lower esophageal sphincter because those nerves that supply the area aren't sending the messages to do that. So the methods of treatment tend to be to try and target that area and open the lower esophageal sphincter. Botox can obviously be used to relax that area. Relatively easy to do. If you can do a gastroscopy on someone, then you can do Botox to the lower esophageal sphincter in four injections of 25 units in the 4 quadrants. And that just obviously relaxes those muscles to allow bolus to travel into the stomach. The disadvantage is obviously it needs repeating. It isn't a definitive procedure, and that people over time can obviously develop antibodies to it, so it may lose effectiveness as well. But, you know, in your frail patient who's not particularly appropriate for anything particularly significant, it can be an option. You've got your dilatation, which we probably in the UK don't do as much as we potentially should. It's certainly done in the US a lot more. Obviously just dilating with a larger balloon than you would in esophageal stricture or something at your GOJ. And the next to hell is myotomy, which is obviously that cut in the muscle layers to allow the lower esophageal sphincter to make it open, which can be done with a fundoplication, either normally partial at the same time as well. This data is probably getting a little bit old now, but you can see that really the best outcomes are those in patients with type 2, where pretty much everything works okay, although Heller's myotomy is the best. You can see in type 1 that Botox isn't particularly effective, but dilatation and then myotomy is the best. You can see that type 3, right, as I say, probably slightly old data there, and I'll talk about POEM a little bit as well next. And some of them do need repeated interventions for it, and obviously a myotomy is the one that tends not to need the repeated interventions for that. Now, POEM is something that is obviously being done, although we don't have any sort of large randomized controlled trials at the moment particularly, but that is obviously a version of myotomy but done endoscopically, so you don't need an operation for it, although you do still need a general anesthetic generally. And you make that longitudinal mucosal incision to obviously break down that area of muscle to allow the lower esophageal sphincter to relax. There is a growing thought process that using it, particularly in your type 3, your spastic achalasia, where you can lengthen the length of your myotomy, or even doing it in some cases where people have spastic disorders rather than achalasia can be helpful. And as I say, increasing the length of that myotomy is something you may do in someone with a type 3 achalasia. Obviously not available in all centres. Next, come on to hypotensive contractions. So you can see here in this manometric trace, and just to go through it again, upper esophageal sphincter, lower esophageal sphincter. A little bit difficult to see in this, we don't have the formal numbers, but you can see there is some relaxation. But you can see it just doesn't, just looking at the colours, even if you can't see anything else, because we don't have the absolute numbers here, there just isn't very powerful contraction here. And this is your hypotensive contraction, which can produce quite a lot of symptoms in people, quite significant dysphagia. Obviously associated with your connective tissue disorders and things such as scleroderma that we've talked about, Parkinson's disease as well, or on its own. Can be very difficult to treat because there's not many pharmacological treatments that can massively help make that esophagus more powerful. Often your first principles of treatment would be to adapt someone's diet, get them to eat softer diet, even a liquid diet, give them good techniques, sitting upright, eating small amounts and often. Speech and language therapy can sometimes be helpful to give people techniques of how to swallow and how to use position and things to help with that swallow a bit more. Prucalopride, I think there are trials going on in esophageal hypermotility looking at prucalopride, obviously a 5-HT4 agonist, obviously used predominantly in chronic constipation patients. I've certainly used it a few times in people with this with varying effects. Doesn't seem to be particularly long lasting, but in a world where there is not much we can give pharmacologically for this, it's always something that's worth trying. Some patients do end up needing supportive feeding with this, either being via a PEG or a PEG-J, because they just can't simply swallow things down anymore. Really variable in the amount that people get with it. Another area where you can have quite significant hypotensive contractions is obviously in reflux disease, which can make the management of reflux quite difficult. You'd always manage reflux as optimally as possibly with any hypotensive contractions. Obviously, it can be a bit of a chicken and egg, because if you have hypotensive contractions and don't get good clearance waves, then you are going to get reflux and you're unlikely to be able to clear that very well from your esophagus. So we always recommend treating that quite aggressively. As I say, you can have hypotensive motility associated with reflux disease, which paradoxically can sometimes get better after you've had surgery for that. Sometimes this can be useful where your solid swallows can be more helpful, because it may look quite hypotensive with water swallows, but when you introduce a solid swallow, so something a bit more difficult that provides a bit more of a challenge to the esophagus, sometimes you'll see that the esophagus will be able to produce a good clearance wave, indicating it's got some physiological reserve to have to deal with a more difficult bolus when it has to. Okay. So next is jackhammer esophagus, or your hypertensive esophagus. And this is when you have your DCIs that are over 8,000, which can cause quite significant symptoms in patients. As I say, this is a group where you may sometimes consider, well, you try medications first. I think limited effect in some of them. GTN spray can be used, particularly around meal times if tolerated. Calcium channel blockers can be helpful. Sildenafil has had occasional use, although it's not been used excessively in this market. POEM has been suggested as a way to obviously make a cut to stop that spasm from being allowed to happen. But this is obviously what it appears like when you do your high resolution manometry, with that big, long, wide contraction that's going on for a long time, lots of vigor, and as I say, always associated with symptoms over 8,000. Okay. So here you have your diffuse esophageal spasm as well, which is obviously lower down in the flowchart on the Chicago 3 classification. And as I've said before, what's important here is to note the distal latency. Now, this manometry trace has been squashed up a little bit to fit it on the screen, but you can see that the time from opening your upper esophageal sphincter here to the contractions down here is shorter, so your distal latency is shortened then. And a lot of the medications that I talked about before would be similarly applied in principle in this scenario as well. Okay, so I'll just do 1 or 2 cases because I think it's always interesting to help exemplify this with some cases. So use some cases from clinical practice recently. So we had a 52-year-old lady who complained of quite significant dysphagia. She'd had it for a while, but it got worse over the last sort of 6 to 8 months, and she was starting to lose weight with it. That weight loss was clearly associated with a decreased input, and she was just struggling with it. Okay, so just to say before this, she'd obviously had a gastroscopy, which was normal, and then she went on straight away to have high resolution manometry after that. So you can see this is one of her water swallows from her high resolution esophageal manometry. There'll be a few more examples to show. Let me pull my other one up. Yeah, got here. So you can see opening of the upper esophageal sphincter here. There's no real peristaltic wave that you can see at all. And then there doesn't seem to be a particularly significant band of pressure with the lower esophageal sphincter. She has another swallow here. She's done 2 little swallows a bit close together. But you can see again, there's no peristaltic wave at all. And the lower esophageal sphincter, it's not massively obvious there, but let's get this. So this is obviously our numbers that we get out, and you can see that our IRP here is 14, so within normal range. So the question is, what are we dealing with here? She's got quite significant dysphagia, and is this just hypomotility that's causing this, and she's not getting things down because of that? She then went on to do her multiple water swallow, so she drank 200 mils of water very quickly, and you can see that this changes things quite a lot. So what we are seeing clearly here is massive panesophageal pressurization throughout the esophagus on that. You can see she's really tried to drink things with it. That changes things a little bit, because obviously if this was just hypomotility and the esophagus not able to push things down very well, wouldn't expect to see this panesophageal pressurization later. So the question is, what is the diagnosis in this scenario? Now I can't hear or see any chat. So this, in this scenario, was classified as Achlasia variant. So although the lower esophageal sphincter was within normal pressure, everything else about it, the lack of peristalsis and then your panesophageal pressurization does go with Achlasia. However, it's important to make sure that that's the right diagnosis before you move on to offer any interventions for that. So she had a past medical history of breast cancer. For this, she had had a mastectomy and some radiotherapy as well. So that's important in our differentials. It's important in what we do in assessing her. It was also the middle of COVID, so there was not much happening. There was certainly no surgery happening, and there wouldn't be for whatever length of time because all of our cancer operations had stopped as well. So the question is, what would you do and how would you manage this woman in normal circumstances and view of COVID as well? So what happened is she had an endoscopic ultrasound, and that was because of the history of breast cancer and the slightly atypical appearances to ensure there was no distal obstruction lesion, no EGJ outflow obstruction that could be contributing to symptoms at all. But at the same time, she had Botox applied to see if this helped. Now, this was done for a number of reasons. First of all, I did talk to our upper GI surgeons, as obviously if a myotomy is being considered, they'd rather that you hadn't done any Botox before, because it can potentially cause scarring and make the myotomy a little bit more difficult. But as I say, it clearly was not going to be offered at that point, so we had to do something. What was also good in her is because her manometry was achalasia variant and not classic achalasia, it was helpful to see if it helped with her swallowing difficulties, because if it did, it would make a decision to go forwards with Hella's myotomy and much more easy, because you'd know that what you were doing would be the right thing. And in fact, she had a really good response to her Botox, and it helped her a lot. And she's now on a waiting list for a myotomy and much happier. Okay, so the next case I have is someone who describes, I think they're a 40-year-old male, and they describe occasional dysphagia with pain and some dyspeptic symptoms as well. Okay, so this is our manometric trace here. So you can see they've got nice opening of the upper esophageal sphincter, pretty small peristaltic wave, looks coordinated, things look like they'd be okay. Do have some opening of the lower esophageal sphincter in the deglutitive fashion there, and then you can see the lower esophageal sphincter as well. Okay. What you can see here though, or let me move on to the next one, is that our IRP is raised in this scenario. So the IRP was 21.1, so raised, but we've got clear peristalsis there. So that moves us down out of the achalasia variety down into one more. And what was interesting and helpful here is they had the multiple water swallow or the rapid drink challenge. But it's not great peristalsis, but what you can see is there's clear emptying of the lower esophageal sphincter. So it's clearly allowing things to go down when challenged with a little bit more volume. Okay, so what does this show? I've already said that, sorry. Clear opening of your lower esophageal sphincter on your multiple water swallow, but you can see how that gives you additional data. Now, I don't think, unfortunately, this person went on to have solid swallows, which probably would have been helpful in this scenario. This is outflow obstruction. So how would you evaluate next? And in that scenario, you just need to think about if there's any reason to be concerned about anything that could be distally obstructing the lower esophagus. Obviously, endoscopic ultrasound would identify anything very close or any submucosal areas, or CT or cross-sectional imaging can be used in that scenario. You can sometimes quite often get people with these appearance where there is nothing that you can see, say on CT or endoscopic ultrasound, and it's probably an anatomical variant for them. Okay. So this is a patient with chest pain on swallowing, and what you can see here is some focal mid-esophageal spasm here in your high resolution manometry. So you can see that that's occurring a little bit too soon. And they were given a nitrate donor, so sildenafil, which improved their symptoms. It's difficult to try and use in this scenario because it's obviously off license and it isn't an area that I think is particularly worthwhile for sildenafil to explore anymore. Okay, so HRM, we've talked a lot about how can it guide what we do on our therapy and how can it identify what the underlying cause of symptoms is, so you can try and guide your therapy appropriately. Okay, this was a patient with dysphagia post-fundoplication. Now, a little bit more difficult to interpret because obviously it's anatomically a surgical, post-op surgical appearance. But what you can see here is quite a tight band here, your lower esophageal sphincter, which you'd obviously expect because you've got your wrapper, your fundoplication around it as well. But what you can see here is this high pressure zone when they've tried to swallow with their peristaltic wave just sat above that area, which would potentially cause quite a lot of symptoms. It'd be helpful if we had some impedance data here to see as well. And what this showed is that you had also had a significant rise in intrabolus pressure above your gastroesophageal junction, which showed that the wrap essentially is too tight and is causing those symptoms. So in this scenario, you know that doing the dilatation of this wrap would be helpful to help with symptoms. And indeed, that's what's happened to this individual, and their symptoms improved after that. Okay. So just a little bit, I've talked a little about impedance, so just to talk about it, obviously impedance is a measure of resistance and the number of ions present. Air has a high impedance. Obviously acidic contents have a low impedance, and what you can get on your manometry, and most manometry catheters will do this for you, is this purple wash, which is a measure of your impedance. And this is just to exemplify this, and it's also just to show a transient lower esophageal sphincter relaxation. Because what you can see in this scenario just before this swallow, which is really occurring here, is you've got your lower esophageal sphincter sat there, and then you're getting a relaxation of your lower esophageal sphincter, which is allowing gastric contents to travel up into your esophagus. Then that is prompting a clearance swallow, which is a normal physiological response to clear that contents back into your stomach. And these are obviously a normal occurring event, predominantly done to allow pressure to equalize within the stomach and to release pressure from the stomach, but associated with reflux, and potentially sometimes thought to be a target for different types of therapy. So just going to talk about another situation that you may come across in high resolution manometry. We've talked about how manometry has done a lot for dysphagia, but also for symptoms of reflux or regurgitation or vomiting, particularly difficult to control vomiting. And this is a scenario of that ilk. So what you can see here is this manometry trace looks quite messy, and unfortunately that's, as we all know, real life, and sometimes we'll get changes like this. And it looks quite different to what we've looked at before. Now, if I just get my mouse back, you can see your upper esophageal sphincter here. We can see we've got an opening here, and this has been pulled out quite a lot as well, actually, to really emphasize this part. You get a bit of a peristaltic wave here. We've got a band that is our lower esophageal sphincter here, but then what you can see is this big pressure below. And what's interesting to note is you can see a symptom has been recorded here, which is nausea. So it can be really helpful to record symptoms on your manometric trace, because then you can see what events are associated with what symptom. So the patient's obviously reported to the physiologist that they have some nausea here, and then this has happened. And this area here is obviously happening below the lower esophageal sphincter. So this is raised or increased intra-abdominal pressure. We've then got an associated, subsequently opened upper esophageal sphincter. And I think what you can just see here is regurgitation is written here. So meaning that the person has either vomited or regurgitated here. Now, what this actually is, this is a case of rumination syndrome. And so the patient has described a symptom, felt some nausea, and increased their intra-abdominal pressure by tensing their abdominal muscles, raising that gastric pressure to force gastric contents back, open their upper esophageal sphincter to vomit it out. Okay, so rumination syndrome is something that I did look at and classify when I did my MD with Mark Fox. And it's something that we are seeing increasingly commonly. You could argue that you can diagnose it without any tests, without any investigations, but particularly those who come to us within hospital things and often have very difficult to control symptoms and have had them for a long time. Now, it's an abnormal behavioural response to unpleasant digestive symptoms, and it's classically the effortless return of gastric contents to mouth, obviously normally around times of eating, because that's when it's there to turn back. It's a subconscious behaviour. People aren't doing it consciously, and it's often like a habit. It's something that was initially done in response to a painful stimuli, whether that be an episode of reflux, whether that be pain from functional dyspepsia or impaired accommodation. And initially, the regurgitation or the vomiting or bringing back the food would improve the symptoms or make things a little bit easier. But however, over time, that has become the body's learned habit in response to any of those episodes or those symptoms, even when it's not particularly helpful. Okay. Previously, it was thought to only really be identified in those with learning difficulties and things, but we're seeing it in everybody, in lots of people. And it can be a difficult diagnosis sometimes to reach, partly because there is a bit of resistance sometimes from patients as well. Manometry can help make the diagnosis, impedance can be helpful as well, but it can also be useful for some of the therapy as well, because really biofeedback would be our mainstay of treatment for this, and that is to teach patients diaphragmatic breathing, where you teach them to relax their abdominal wall, to take those breaths in where they're pushing out their stomach while they're breathing in, which prevents them from being able to tense their stomach and being able to create that abdominal gastric pressure required to return that contents back. And doing that with the manometry cathetering can be really helpful. Manometry, as you've seen, is actually fairly intuitive. You can see that the different colours represent different pressures, and you can see from that manometric trace we had from rumination before, you can see that big gastric strain that isn't occurring in other scenarios. And it can just be useful to do the biofeedback with the catheter down for people to be able to visualise what they're trying to do. We've had a little difficulty with that with COVID, because understandably, particularly before vaccinations and things occurred, they were not so keen to do manometry on people when they knew they would get vomited on in the middle of a COVID pandemic. You also want to treat the underlying trigger. So if pain or discomfort or dyspepsia is one of the predominant symptoms, treating that. Obviously things such as tricyclic antidepressants such as amitriptyline can be useful for that. Or if reflux can be a driver, using PPI can be helpful for that. Though by this stage, if people are getting to manometry, they've probably already gone through PPIs and things. Baclofen has been used to treat rumination. Obviously, there's been an interest in it because of its reducing the number of transient lower esophageal sphincter relaxations. So it's thought if you reduce those, then it would be harder for patients to ruminate. And it did prove to improve symptoms and reduce rumination events, but there was no significant change in the number of transient lower esophageal sphincter relaxations, therefore suggesting that the central sedating effects were probably the reason behind that. I've still used it, still can be useful. It's a drug a lot of us are familiar with and can be helpful in that scenario. Okay, so, have I gone the wrong way? Or am I just showing you again? Okay, and this is just another example, not quite as extreme of rumination. So it's not always that one that if we just go back to that's really dramatic and really awful. But sometimes people can do it quite easily, particularly if they've sort of learned how to do it around the time of a relaxation of the lower esophageal sphincter. You can just use small amounts of gastric pressure to return that gastric contents. Okay, so this was a case of recurrent vomiting with PPI resistant reflux that was rumination syndrome in the end, who improved with diaphragmatic breathing and with amitriptyline as well. Okay, so that is my description of high resolution manometry, the principles used to look at underlying motility disorders to assess what's happening with the disorder, and to try and, using your Chicago classification system, to use a systematic approach to try and look for your differentials of what's causing it. It doesn't always fit neatly into the box, as you know, we know with all types of medicine, you know, there's always cases where it's not very clear, it's a mixture of things, but it can be a guide as to what you can try and help your patient. Thank you.
Thank you, Emily. It was...
Oh, you've just muted.
Thank you, Emily. It was a wonderful talk. Thoroughly enjoyed. I'm sure all the postgraduate students attending here have learned a lot. Certainly, there would be a lot of burning questions on the issue. So, Saqib, are you there to take up, to ask questions which have been put up on the chat? Thank you.
Once again, Emily, thank you very much. It was a very nice overview and a masterclass. So a couple of questions. One from the audience is, where does EndoFlip fit in? Have you got any experience with EndoFlip?
So I used EndoFlip in some reflux patients. I know it's being used more now. What I think is difficult is to have normal values that can be applied across a population. I think in an individual where you're looking at pre and post interventional procedures, it can be helpful. But I think having normal values, there's so many variables involved. I think it can be difficult to use it for that. So I think if you're looking at therapy and you're looking at intervention, you want to assess before and after, EndoFlip can be helpful for that. I'm not sure if it's particularly helpful to extend beyond that, really.
Thank you very much, Emily. There's another question regarding the diagnostic approach to dysphagia. So is it normal practice to generally get a barium swallow prior to proceeding with manometry studies? And if so, then what additional information it can give? Because a lot of people before doing POEM get bariums as well.
So I think it's probably more important when you're looking at doing an intervention such as POEM. I certainly don't do it as standard in dysphagia. I'll always do a gastroscopy, obviously, before doing manometry, but then I would go on to do manometry next. I think it can be helpful if you're looking at structural things and if you want to say identify hiatus hernias a little bit more clearly and see what they may have an effect on things. But I don't think you absolutely have to do it. But I think as a pre-surgical approach, it probably is helpful if you just want to look at that structure in a bit more detail.
Right. So I'm going to ask you one question, Emily. You emphasized about classifications, Chicago classification, and subcategorizing Achlasia, and you mentioned about nicely about Botox and balloon dilatation has the role. Now, POEM obviously is more in fashion, and people want to know more about the POEM. Which classification it does fit in? Would you recommend for all three subgroups, or is there a particular pathway you use, or how do you select your patients for POEM?
So I would tend to, I think obviously type 2 and type 3 would potentially be your better for POEM and for patient preference. I think there's still a lack of evidence to sort of clearly be sure. And I think it's a lot to do with patient preference. And I think it depends on availability as well. Within my own hospital, we don't have anyone offering POEM at the moment, although we do have a regional area that we can send to. So previously, when we would send people to the clinic, they'd see both a surgeon and a POEM endoscopist and have a sort of MDT discussion about it. And I think that's probably the stage we're still at the moment.
Yeah, and I think it's important to recognize which age group is going to benefit. So if you've got elderly 80-year-old non-malignant dysphagia cause and you got a diagnosed Achlasia, I think it's worth to try Botox. Sometimes it does have effective.
I
so
absolutely
there,
agree with that. Yeah, I think you've got to look at do no harm first of all, don't you? And if doing a few gastroscopies in the remaining lifespan they have and reducing their symptoms is definitely safer than say a Helles or a POEM.
Definitely. So there's a question, what is 30 centimeter isobaric contour? What is its significance? I'm not sure if I understand this isobaric contour.
So
do you understand?
So you can on your manometric trace, you can set a 30 millimeter mercury isobaric contour, and that would be looking for breaks in peristalsis generally, to see if that pressure is changing between those. That's fragmented peristalsis is probably when it's most useful, just to look at that in a little bit more detail. It's not particularly in the looking at your Chicago 3 classification.
So when you're preparing your patients for HRM studies, is there any particular instruction? For example, medications, do you ask them to stop PPIs? A lot of people are taking opiates or tramadol, etc.
Yeah. In an ideal world, you'd like them to stop a lot of the medications, particularly say things like opiates. But I think trying to get someone to stop opiates or something for manometry is very difficult. Obviously, trying to stopping PPI so you can do the pH study off PPI, particularly if you don't have impedance data there, is important. Other medications, I'd want to stop baclofen before opiates. I don't think it's feasible to do. And benzodiazepines and things can have an effect, but I think often people are unable to stop them without a long wean for that. So I think you just accept that they're on it. It may affect the motility normally to reduce it, and just to be mindful of that when you're looking at the report.
Thank you very much, Emily. One last question from my side, and then I'll open it to the other panels. So hiatus hernia and reflux is a very common condition, especially with rising obesity as well. And a lot of people don't like to take PPIs and they want surgical treatment for that. So we do pH studies with them. Do you think they need HRM studies before they have surgical repair of the hernia, or is not relevant with that?
I think it's important to do because you need to know there's no major motility disorder before you then disrupt things from an anatomical view. It is difficult because reflux can be associated with hypomotility, and paradoxically, some of those patients will improve the motility once the reflux is treated. The DCI is something that the surgeons will always look at. But the example of a group where that actually doesn't affect it is your Achlasia. You'll do a myotomy often with a fundoplication, obviously not a full wrap at the same time, and most of them won't have any dysphagia or anything afterwards. But I think you need to know that the esophagus is going to be able to cope with whatever intervention you're going to do as surgery. So I think you should have HRM before any hiatus hernia or reflux surgery.
Excellent, excellent. Professor Alam, over to you, please.
Thank you very much. I think Nadeem has a few questions and comments to make. So I'll invite Nadeem Tehami, please.
Thank you, Professor Alam. Emily, thank you very much for a fascinating talk. To be honest, my questions are may sound very simple, and I'm going to ask those questions out of my ignorance rather than having an understanding of this really challenging area. And I think you summarized the issues really well. So the question, I mean, I hope, please accept my apologies for a simple question. Now, patients who attend diagnostic endoscopy session for reflux disease, at what stage would you like those patients to be referred for upper GI physiological studies? So they'll come in, we'll say, okay, there isn't any obvious complication associated with reflux disease, just carry on with the PPI, and then may come back or sort of get referred. So as you see, obviously, they get discharged to the general practitioner most of the time. So that would be the question number one, if you could answer, please.
So I think it's about what you're going to do with the results. So I think if someone's got a bit of reflux, but they're either fully or mostly responsive to a PPI, my question would be is what would you do differently with your manometry and your pH studies? So I generally ask the question about if their symptoms are controlled and whether they would want to consider surgery or not. Because if they say I'm controlled on my PPI, as long as I remember to take it, I'm fine, then I wouldn't go ahead and do manometry and pH studies because I wouldn't do anything differently with it. The other time I'd consider it is if there was some diagnostic uncertainty where it was a little unclear whether what this just was simple reflux. But I think that as with all tests, it's what are you going to do with the result? And if the result isn't going to change your actions, then I wouldn't do it. So generally, if they want surgery or it's atypical symptoms and it's not clear reflux is the cause.
Thank you. And the other question is, obviously, as you said, POEM isn't kind of widely available. Again, obviously, colleagues here in our center, they do offer POEM, but actually I don't do any gastroenterology, so my understanding is very limited. However, I mean, the patients back home, especially the audience in Pakistan, this question gets asked. So if a patient is a potential candidate for POEM in the future, does dilatation and Botox injection impact the outcome of POEM intervention?
I think I don't know enough about that data offhand. Botox could theoretically, as with before Hellas myotomy, potentially cause some scarring and make things a little bit more difficult. Dilatation is that, I mean, if you're going to wait, it's about balancing what you can offer now to help with symptoms versus what could be potentially done in the future. I think dilatation would probably be likely to have less of an effect because you've got a circumferential dilatation occurring rather than focal areas. So I think you just have to have that conversation with your patient. But I think dilatation will probably be the lesser of the two to have an effect, unlike the Botox. And if someone's going to have to wait a long time for a POEM and you need to offer something, then I think then you go ahead and you do that.
Great, thank you. Now, I do endoscopic ultrasound scan, although predominantly it's all done with HPB colleagues. But I haven't received any referral for achlasia or pseudo-achlasia. So I just wondered what your thoughts would be. So, I mean, does it US has a role, or I mean, how would you sort of go about investigating the pseudo-achlasia?
So it depended on my index of suspicion. So say it was quite an elderly patient who had presented with what looked like achalasia, I'd look a lot harder for pseudo-achalasia in that patient. But quite often I'd CT. And I think the majority of these cases in a pseudo-achalasia, you'll see it on CT. There's just a small number where endoscopic ultrasound, where it's a submucosal tumour. I know of one case we had I think a 51-year-old woman who turned out to have a submucosal tumour causing this. A lot of the outflow obstructions tend not to be anything sort of significant to worry about. And I think probably partly availability that CT is probably done as at the forefront of this, and endoscopic ultrasound only in those where there's a bit more of a significant index of suspicion, or if CT hasn't shown anything, because you could end up doing it in the US and loads of people, couldn't you, otherwise, which isn't necessarily appropriate nor feasible.
Thank you very much, Emily, and thank you for taking my simple questions as well. So, cheers, thank you.
Thank you, Nadeem. One final question, and then we'll close the session. We have a patient who has a normal endoscopy, no hiatus hernia, but continues to have reflux symptoms. What would you prefer, HRIM or 24-hour pH monitoring, or what?
So in that scenario, I would do HRM first, because I'd want to know what the motility looks like, because obviously it could be that it's very significant hypomotility, which could make any even small element of reflux worse. And then I would do pH studies on that patient, because you know, if you're going to talk about anti-reflux surgery or other interventions, you need to know, is what you're going to do make a difference? And I think the scenarios, you get a lot of people with reflux type symptoms who turn out to have pretty normal HRM and normal pH studies, who obviously you don't want to operate on then. And that's more when you're looking at your sort of functional dyspepsia and scenario. So yeah, if people were not responding or wanting surgery, I'd always do HRM with pH studies. Your HRM also helps you place your pH probe, so it lets you know where to put it to the right distance. So it's important to do it for that reason as well.
Thank you, Emily. Shanil, do you want to make any comment, please?
Excellent talk, Emily. No, I think I'm okay.
So, Saqib, if you permit me, I'll close the session. It remains for me to thank Emily for providing wonderful, food for thought and a wonderful session on esophageal motility. Thoroughly enjoyed, learned a lot. And I also thank all the participants for their active participation, asking questions. Thank you, Saqib. Thank you, Nadeem, Shanil, and everyone present here. Finally, I hand over to Wilson Pharmaceutical, Saeed, for your concluding remarks, and we close this session. Thank you very much, everyone.
Thank you so much all for sparing your precious time. We shall be on air after 2 weeks. It's now a fortnightly program. Thank you so much.
Okay. Thank you very much. Thank you, Emily. Thank you, everyone. Bye-bye.
Thank you, Emily.
Good evening and good night.
Bye-bye.